My name is Bonnie Zimmerman. I'm a program specialist with the Office of System and School Improvement. Today's topic is Mental Health 201, Integrating Mental Health Supports in the Younger Years. We chose this topic because statewide we are working toward a whole child focus. We want students to be able to come to school and learn, and for schools to honor the needs of its students with supports that make that possible. Having a systems approach is vital to noticing the students who might fly under the radar, and we want to help you get started. This afternoon, we're joined by Megan LaPalme, OSPI Program Supervisor for Project Aware and School Climate Transformation. We also have Sarah Ellsworth, Behavioral Health Clinic Services Manager for True North at ESD 113, and Chelsea Cornwall-Brady, Assistant Principal at Olympic Middle School in Shelton School District. They'll be talking about their experiences with implementing an integrated system of supports. Thank you all for being here. Oh, let me give you a little bit of background on this, on our objectives. Today's objectives will help you define mental health services and what a mental health professional can provide in schools, identify the barriers and how to overcome them at the elementary level, how to integrate supports into a school structure, understand what supports do and don't look like in a learning environment, how to change the culture of a school around mental health. You'll learn how Shelton School District is implementing these supports, and you'll get some great resources at the end. Now we have Megan. Megan will frame this for us and get us started.
So just a little background about our grant project. Project Aware is a 5-year federal grant we received in 2014. It's about $10 million over 5 years, and it gave us the funds to work with 3 school districts in Washington. Unfortunately, the grant sunsets this September, but we have a lot of really good stuff coming out to share with everyone. Through the grant, we worked with Marysville, Battleground, and Shelton, who are here today to share with us. So with Project Aware, we focused on 3 big components. We have behavioral health service delivery in school buildings and in community settings, developing tiered systems to support appropriate service selection, referral, and delivery, and mental health literacy for staff and students through partnerships with ESD 112 for youth mental health first aid training, and with CHI Franciscan and Jordan Binion Project for developing and delivering the mental health in high school curriculum. We had some big things that we learned through Project Aware, and I'll just share the quick takeaways before I hand it over to our folks at ESD 113 and in Shelton. So first of all, behavioral health services are not a magic wand. They don't cure all the problems within the school, but they certainly help. A multi-tiered system of supports critical for behavioral health services to be successful. Fully integrating services of any kind into the school system increases likelihood of success and positive student outcomes. So instead of just co-locating a service provider, we want to integrate them into the school system. Mental health literacy reduces stigma around mental health, and that's true for staff and students alike. A big one that we learned is that behavior concerns are not always mental health concerns. So a student might have a behavior issue, but they might not have a diagnosable mental health disorder. And district capacity for supporting behavioral health work in the school is really important for successful implementation. So if we have district folks that are helping to drive the work and support the people that are doing the work in the buildings, it's much more likely to be successful.
Thanks, Megan. This brings us to our first polling question. We like to know who's in the audience so we can tailor our content to your needs. And as we go along today, we'll pause at polling questions to answer any questions you might have. So please use the question and answer button at any time to ask our presenters more. With us to help answer the question why is Sarah Ellsworth, Behavioral Health Clinical Services Manager for True North. Sarah will talk a little bit about layering supports, barriers, and how they're approaching mental health in schools.
Excellent. Okay, so I'm just taking a quick glance to see who's here. It looks like we have a significant number of counselors, some administrators and teachers, and a lot of others. I'm curious who the others are. Maybe we'll find out. So I'm going to talk a little bit about why we want to implement mental health services in schools and what some of the unique challenges are doing this in an elementary building. So who am I? My name is Sarah Ellsworth, and I am the Behavioral Health Clinical Services Manager for True North at ESD 113. ESD 113 serves the Capital Region. We serve a 5-county region that includes Thurston, Mason, Grays Harbor, Lewis, and Pacific counties. Within our region, we have 44 public school districts and 1 tribal compact school, approximately 73,000 students. I work specifically in our student support division, which deals with non-academic barriers to success. And for the last 11 years, I've worked for our True North Student Assistance and Treatment Services. True North provides behavioral health services, including both mental health and substance use, to students in our region between kindergarten and 12th grade. Provided substance use disorder treatment services for about 20 years, and we added mental health services about 5 years ago. I'm going to talk to you about some of the reasons we added those mental health services and what some of the benefits have been. So the first thing I want to talk about is why mental health in schools. Schools are in the business of educating students. Why is this something that they may want to pay attention to? We believe there are 3 main reasons, one of which is Washington State students are experiencing significant mental health issues that seem to be getting worse over time. Student mental health issues we know have significant impacts on academics and education, and students are not, in our region, we notice are not connecting with mental health services that are available in the community. For these reasons, we decided that schools were the ideal place to deliver mental health services, and partnerships were critical. So when we look at the data, I'm going to share data from the Healthy Youth Survey. For those of you who are not familiar with the Healthy Youth Survey, it's a survey that's provided to Washington State students every 2 years in 6th, 8th, 10th, and 12th grades. It is a collaborative effort between OSPI, the Department of Health, Healthcare Authority, and the Liquor and Cannabis Board. And it asks a host of questions about health-related behaviors, including mental health and substance use. The mental health and substance use questions are not asked to 6th graders, so I don't have specific elementary data, but what I do have is 8th grade data that gives us an indication of what students are carrying forward. What we know is many students are experiencing mental health issues for a significant amount of time before they ever share those needs with other people or seek help for them. So the 8th grade data gives us a pretty good indication of what might be going on for our elementary school students. So when we look at 8th grade depressive feelings, the question is worded on the Healthy Youth Survey as students who report feeling sad or hopeless for at least 2 weeks in the past year. Approximately 32% of our 8th grade students in Washington State answered that this is the way that they are feeling. So at 1 in 3 students, it's pretty significant. We also have them answer questions about their feelings of being anxious or their inability to stop worrying. These questions are worded as students who report feeling nervous, anxious, or over the edge, or not being able to stop or control worrying in the past 2 weeks. So these are pretty current answers. Again, approximately a little over half of our students are saying they're feeling anxious, nervous, or on edge, and 45% of the students feel like they are unable to control those worries. These are very concerning things when we think about these students sitting in classrooms and how they might be able to access what they're learning when they're feeling depressed and so nervous that they're unable to stop worrying. We also ask questions about suicidal feelings and actions. There's a series of three questions that are asked. The first is students who report considering or having thought about suicide. The next is whether they have made a plan for suicide. And the final question is about whether or not they have attempted suicide in the last year. These pieces of data are very concerning. About 1 in 5 of our students reported having considered suicide in the past year. About 16% of those students actually made a plan, and 10% said that they had attempted suicide in the last year. When we think of an average classroom of 20 to 30 students, that's 2 to 3 students in every classroom who have made a suicide attempt. It is important that we as educators are paying attention to this. Some other considerations about what's happening in Washington State compared to other states is annually Mental Health America issues a policy paper called the State of Mental Health in America, and it ranks states in terms of how they're doing in responding to the mental health needs in their communities. There are adult rankings and youth rankings. What I'm sharing here with you are the youth rankings. So Washington State is 31st in the country for youth access to mental health care. It's not great, but it's a significant improvement from the last 4 years when Mental Health America started issuing these papers. We're 25th in the nation for children who experience a major depressive episode but do not receive mental health services. 42nd in the nation for students identified with a serious emotional disturbance for an IEP. When I first saw this statistic, my thought was, well, that's not bad. We don't have that many students who are needing IEPs for their social and emotional needs. But the perspective of Mental Health America, which I tend to agree with, is that states who are doing well addressing their students' mental health needs are identifying their social emotional needs early and writing responsive, individualized education plans for those needs. Washington State is one of the lower states for doing that. And when we can identify early and provide supports at an early age, the interventions tend to be less costly and less intensive than when we wait longer. One area where Washington State is doing well is we are 3rd overall for parity. What parity means is that mental health and substance use are treated the same as physical health, or access to mental health and substance use services are the same as access to physical health services. Approximately 4% of children in Washington State with private insurance have private insurance that doesn't cover a mental or emotional problem. So that means 96% of our students with private insurance have access to parity, meaning that they can access their mental or emotional services that they need. So Megan introduced Project Aware. We were able to start up our mental health services and partner with Shelton School District as part of Project Aware. Megan touched on some of this, but the overarching goals of Project Aware were to improve school climate and safety, increase mental health services for youth, and raise awareness of mental health issues amongst students, staff, and family members. When we started our mental health services, what we realized is it had to be more, as Megan indicated, than co-locating or putting a counselor in a school and expecting them to do outpatient services as they normally would in a traditional setting. We really wanted to develop an integrated model. And so this really is to help identify how our integrated framework is different than a traditional mental health model. So in a traditional outpatient mental health setting, what you have is a mental health counselor who sees students for appointments. Students show up, they provide the behavioral health services, and they go home. Generally, I come from a community mental health background. We don't talk with the school. We don't find out how they're doing educationally. We may ask them questions about that, but we never check in with school staff to confirm what we're hearing. Also, in a traditional outpatient mental health setting, mental health staff use their own language when providing care. We're generally using evidence-based practices that come along with our own unique language. We're teaching students what that language means, but we're not integrating it with language they're hearing in other places. And in a traditional mental health setting, it's the clinicians or therapists who are doing the mental health services. This is different in our integrated model, where the mental health staff person is engaged at all tiers of support. The school are aware of the interventions that students are receiving and oftentimes engaged in supporting or also participating in those interventions. Our mental health staff also take responsibility for adapting our language to fit with school-wide language and school-wide expectations. One of the things that we ask our staff to do at the beginning of every year is to sit down with their school counselor or school administrator and say, tell me what your school-wide expectations are and the language you use to teach these expectations to students. And we adapt our therapeutic models to align our language with the language that they're already hearing. And in our integrated framework, we believe that responding to mental health needs is more than just the therapist's job. It's everyone in the school building's job. Our clinicians are part of an integrated plan and really at the top of the MTSS triangle, responding to those with the most significant need. In our model, we say our therapists wear two very distinct hats. One is that of a therapist providing therapeutic intervention, and one is that of a liaison. One thing to know about school-based mental health services is that they do not meet the needs of every student. Some students have discomfort with receiving school-based mental health services and would prefer that service to be received in the community. Some students have needs that are more significant than can be met by a school-based mental health provider. And so when that's the case, rather than say, I'm sorry, we are not going to meet your needs, we really take on the role of liaison and helping connect them to those more appropriate services. So our staff in schools are doing anything a general therapist would do other places. We're providing screening and assessment, individual, group, and family therapy, co-occurring treatment, both mental health and substance use when indicated, and case management and care coordination for the students on our caseload. But in addition to that, we really see ourselves as the liaison between the school and the outside larger behavioral health delivery system. We provide care coordination and referral to students who need additional services than what we may be providing them, or different services than what we have to offer in the school building. When students, what happens oftentimes is a student actually is referred by the school who doesn't know that they might already be receiving outside behavioral health or mental health services. And when a student comes to us and we become aware that they already have services, is we really try to make a connection with that outside provider and find out how we can provide support there in the school. If there is a crisis plan, if we can make sure that that's accessible to the school, that the student knows that we are there as a resource if they experience some sort of crisis or need during the school day. And then our job becomes to link that communication back to the outside provider. We also regularly participate in wraparound teams. I'm not sure if everyone listening is familiar with WISE, which is Wraparound with Intensive Services, but it's the highest level of mental health service provided to Medicaid-funded youth in our state, and it's 24/7 support. And so it's beyond what we would provide in a school-based model, but the hope is that at some point students stabilize and step down from their WISE provider. So we start to participate in those services, those wraparound meetings at the very beginning of care, with the hope and the belief that at some point that student will step down and we can have a very seamless transition. Also, wraparound providers are community-based. They're not in the schools. And so if the student does have a crisis while they are at school, we can be part of that response team. And our staff are also engaged on MTSS or student support teams as appropriate, providing consultation and support for the development of the tiered model. When we talk about building a multi-tiered system of support for mental health, one of the things that happened when we were awarded our Project Aware grant is we had written in a number of multi-tiered supports. This was all new to me as not a school person, but a mental health delivery person. And I thought, this all sounds really great. And we'll do it because we said we do it, and I'm type A and I want to do what I said, but I didn't really understand how important it was. Now I recognize that you cannot do this work in a school without the framework of a multi-tiered system of support. Chelsea, I'm sure, will speak more to this, but what a mental health provider is able to do at Tier 3 is very limited, and the scope is very small compared to what a school can do to be responsive to student mental health and social and emotional needs. Our model is built on a tiered model. At Tier 1, we have universal school-wide practices that support all students, and these supports are implemented by all school staff. There's responsibility from the janitor to the administrator, and I won't talk too much about these because Chelsea will speak to them later. Tier 2 are really targeted interventions for students with low acuity or transient needs. These are students who don't meet medical necessity or don't have a diagnosable mental health condition, but need something more than what the general social emotional curriculum, school-wide expectations is going to provide. And these supports can be implemented by classroom teachers, school counselors, administrators. And Tier 3 services are those individualized therapeutic mental health services for students who do meet access to care or have a diagnosable mental health need. And these are implemented in our system. We call them student assistance professionals, but those are the school-based mental health therapists. So when you look across the spectrum of supports, what we do as school-based behavioral health providers is pretty limited compared, again, to what the whole school building can do. One of the things that I want to acknowledge is that best for the students with the highest need that will be seen in a school-based program, our therapist spends 2 hours with that student. The classroom teacher, when we're talking in an elementary school, spends 6 hours a day with that student. When you think about impact and ability to change behavior, that classroom teacher has a lot of power. And so we really want to ensure that that classroom teacher is engaged and involved in what it is that we're doing. Let's talk about some of the unique challenges of providing these supports in an elementary setting. There were 3 broad brush categories that we found became challenging once we started implementing mental health services in schools. Those are family engagement, school engagement, and student engagement issues. Family engagement is really challenging in an elementary setting because in Washington State, the age of consent is 13 years old, meaning if you're 13 or over, you can agree to and receive mental health services on your own and decide who's involved. If you're under the age of 13, it's the parent who has to provide that informed consent. This is challenging, and it was a unique challenge for us who have been providing substance use services for over 20 years in secondary buildings, working with students who are almost all 13 years and over. We were used to being able to get a referral, meeting with the student, scheduling an assessment sometime the same day or next day, and getting them started in treatment within a couple of days. We found that it is much more challenging and things move much slower in an elementary level because we have to do that outreach and engagement to parents and get them to agree to the services, get them to come to the school to sign the appropriate paperwork, and get them engaged in the process. This takes anywhere from days to weeks, depending on how involved the parent is. Another challenge that we've had is oftentimes parents have an expectation that the mental health provider is going to fix the child. Now that we are involved, they can step back and they can let us deal with behaviors, and we can wave our magic wand and fix what's going on with their young person, which is not the case. And we'll talk in a minute about some of the solutions that we've come up with that. The 2 other main issues are transportation and technology. So parents, although the school is the location of the services, it is still sometimes challenging for parents to get to that school location to sign those consents and releases and to do that on a regular basis. And technology, contacting parents by phone, oftentimes, at least in the Shelton community, what we have are parents who have a cell phone that does not have a plan but has minutes. Parents run out of minutes frequently. So having that communication and connection to parents and reaching them on a consistent basis can be a real challenge. Also, when we started these services, there were issues with school engagement in the process and what some of their expectations were. So one of the things that we found is referral pathways needed to be established. When we started these services, what we said to the school with the best of intentions was refer anyone and everyone that you are concerned about. Don't worry about whether the behavior that's bothering you might translate into a mental health issue or not. Please just send us kids, because we were really worried that schools wouldn't refer. Unfortunately, we opened the floodgates and they did send us anyone and everyone. And so we really had to take a step back and say, whoa, we need to help schools recognize the right way to make a referral and the right kids to refer. As Megan alluded to earlier, we learned very quickly that behavior problems don't always equal mental health problems. And so we had to do some education and support for school staff around that. There was also an expectation very early on, and I think Chelsea will speak to this as well, that the school thought that we would, again, walk in with our magic wand and we would fix behavior issues and respond to all crises. It quickly became clear that if that was our role, we would be engaged in that full time. And so the school had to make some adjustments that we'll talk about. And another challenge is mental health treatment and academics historically have not been integrated. And so there was some buy-in that we needed to have on the behalf of the school to help them recognize how our services would support the education that they were providing. And then challenges with student engagement, not drastically different than what we see in secondary buildings, but stigma and fear related to services, ability to comprehend traditional mental health language that wasn't developmentally appropriate, and there was often a disconnect between what the goals of the school and family were and what the goals of the students were. So I'm going to talk to you real quickly about some of the solutions that we've come up with to these identified challenges. So in terms of family engagement, we've really tried to individualize our outreach to family based on the unique situation and circumstances of the referral as it presents itself. One of the things that we learned very quickly is some families have a very good relationship with school, and some families do not have a very good relationship with school. And so rather than have one way to reach out and engage families and services, we realized we needed to think about what were the unique needs of that family and who is the best person to initiate that conversation with them. When we have a family who has a very strained relationship with the school, and the school initiates the services and is the one to present that to the family, that often does not go well. And so in those cases, we have our mental health therapist who can be an outside objective person saying, you know, I've met your student, or I've heard about your student. There are some concerns. I have these really great services to offer. We can do outreach that way, and that works really well, and we can build engagement and alignment. In cases where the school has a great relationship, sometimes it's the school counselor, the school administrator, or the teacher who brings up those services. But we really, we try to individualize that based on the needs of the family as much as we can. We also, from the start, want to set realistic expectations with families around what treatment can and cannot accomplish and what treatment does and does not require of families. We use evidence-based treatment models in our programs, mostly cognitive behavioral therapy, specific to the conditions that we're treating. And so one of the elements of those is there's a large component of family engagement and family participation. We let the parents know that from the start, that we are going to be talking to you on a regular basis. We are hopefully going to have you come in and meeting with us on a weekly to monthly basis, that your engagement and involvement in treatment is really going to impact your student outcomes. And we have our staff use motivational interviewing to build that bond and connection, hear families, but also increase their motivation to engage in services. With that, as I said, we have regularly scheduled family sessions to build those relationships, to develop those skills. One of the things that we know about mental health issues, especially those within young people, they're often not individual problems, but they're system problems. And so it's hard for a 5-year-old to get healthy and well in a system that is not healthy and well. And so we want to treat not just the individual, but the system that they are working within. And so family services and family sessions are an important component of that. We also have extended service hours that we provide services within. So the school day generally is something like 7 to 3, 7:30 to 3:30. Our staff don't just work those hours, they work a full 8-hour day. So they have oftentimes before school hours or after school hours to meet at times and in ways that are more convenient to parents. So parents aren't having to come during this regular school day for their family sessions or to have their child's assessment completed. And we also use paratransit. Transportation is a unique challenge in our rural region, and particularly in Shelton. Some family members live very, very far away and don't have transportation. Their students get to and from school in the bus, but parents don't have reliable transportation. For those of you who are not familiar, paratransit is a service that is provided to Medicaid-funded families and young people that will provide transportation to and from medical appointments. Mental health services are considered medical appointments, and so we can use paratransit to get parents a ride to and from the school to engage in their student services. We can also arrange paratransit to return students home after school if they stay late for an appointment, and we often use paratransit over the summer when students aren't actually attending school but continue their services at their school location. Some of the solutions to our school engagement issues were to establish a referral process through their MTSS or student support team. So rather than every teacher in the school bringing a handful or a list of referrals directly to our therapist, they now do that through a student support team that is a multidisciplinary team that includes school staff and our therapist, that includes academic and behavioral issues. So the team can make decisions about, is this a referral right now, right away to our mental health therapist, or are there some tier 2 interventions that maybe we want to try first? That's really helped streamline our referral flow and help us get the right kids to the right service as quickly as possible. We also have, as I alluded to, one of the things that I think the school felt like we would do when we started this service was we would be responding to every behavioral blowout, every crisis that happened within the school. And as I said, if that's what we did, we were responding to every behavioral outburst and every crisis in the school, that would be our full-time job. What we really want our mental health therapists to do is to provide specific evidence-based mental health services to the young people in our care, which means when we are in a therapeutic session with a young person and another student is having a behavioral outburst or a crisis, somebody else has to respond to that. And so there was a lot of building competency through coaching school staff around how you might de-escalate a behavior situation, how you might contact crisis services, what you might do if a young person comes to you and is expressing symptoms of suicide and your mental health provider is in a therapy session or they're at another school for that day. There were a lot of things that we really did around coaching them to help them be responsive. We also do regular classroom observations. One of the things that is unique and interesting and probably not surprising is we as therapists see students as individuals most of the time, and the behavior issues that they're really being treated for or needing support around don't happen in our artificial setting. And so they come to our office and they function pretty well. They're with an adult who cares about them, who's providing a relationship, and they're not exhibiting the behaviors that they're being treated for. And so we spend time in classrooms very purposefully to try and see what's really happening in the context of the classroom in terms of the behaviors that we're trying to teach, in terms of some of the engagement between the classroom teacher and the student, and find out, what's really going on, what's behind it, how we can support the student, how we can support the staff. And then we also try to have regular face-to-face connection with the primary teacher. Ideally, we do this on a weekly basis. Sometimes it really does look like a monthly basis. For our students who are high needs, we're sometimes doing it more often, but really checking in with the classroom teachers to let them know what's going on, how they can support their student, what they're learning. And then finally, our issues with student engagement is we try and build positive associations with student assistance professionals. So our staff who are therapists in the school are regularly out in the school participating in positive ways with students, sitting at lunch with them, just getting to know them, being in the classroom for no other reason than to just be a friendly face, but really become something that's not scary to them. As I talked about, we tried to adapt and align our language to their developmental level. And so we try not to use a lot of clinical speak. We really try and use language that is familiar to them and comfortable for them. And we really take seriously individualized treatment planning. So how do we create a treatment plan that is clear and concise, and it can be understood by a 7-year-old as well as their parents, as well as the school, meets the needs of all people that everyone can agree on. And we spend a good amount of time at the beginning of services doing that. So we are on to polling question number 2.
Right now, we want to hear from you. What topics do you want the support around most? Universal strategies, strategies for Tier 2 schools, implementation prior to referral. We'll give you a few minutes to answer that, and I will introduce you to our next presenter. It's Chelsea Brady from the Shelton School District, and Chelsea's going to share her experience building a successful program.
My name is Chelsea Brady, and as already mentioned, I'm the assistant principal at Olympic Middle School. I've been there just over a year. Previous to that, I was a TOSA, a teacher on special assignment at Mountain View, and my role was to implement MTSS. And that was last year at Mountain View. So that is the work that I'm going to be talking about, is the work that was done last year at Mountain View. So prior to being a TOSA, I was a 5th grade teacher for about 5 years. And prior to that, I was a para for about 7 years. So a little bit of everything. Why did we start looking at mental health in our building? So we felt as a staff, so this was when I was still teaching, that our student population had really changed. We felt like we had seen a shift over the last few years, and that we had much higher needs than we had ever seen before. We went from having maybe a couple of kids in the building that had significant needs to anywhere from 1 to 5, sometimes more kids per class that were really struggling. The things that they were struggling with were more intense and more severe than what we had dealt with before. So we saw an increase in the social emotional needs and also the trauma that our kids were coming in with that they had experienced. We had students as young as kindergarten that had come in with a PTSD diagnosis. We had students that had ACEs, high ACEs score. And so we were unprepared for what we suddenly felt was an increase in these needs. And so, of course, all of that led to increased disruptions to teaching and learning. So at that time, our frustration level from our teachers and from our staff were very high. Our teachers felt that they did not have the training and the skill to address the type of needs that were suddenly in their face every single day. We had kids blowing out of the classroom multiple times a day, and then you have a teacher left with a destroyed classroom and going, what am I supposed to be doing here? I can't keep doing this every day. So it really led from a frustration of what do we do to fix what is happening? And so as a team, we kind of got together to start working on this. And we realized that, our district was working with Project Aware. At that time, they were working mostly with the secondary schools, but we decided to write a proposal to say, hey, I know that we're in elementary school, but we would really love to have a mental health professional. So we wrote a proposal for that. And what we thought we were asking for is not what we got. And it took us some time to really understand how to use what we had. And so what we found is, and you've heard this mentioned a couple of times, but we were really looking for the magic wand. So that's what we were asking for. So we thought we were going to have this person come in, and that clearly the needs that we had were beyond our expertise and that they were a mental health need. And so we thought that this person would come in and fix it. And that if they just had that mental health support, everything would be better, things could go back to normal. That's what we thought. Of course, that was not correct. And as you heard Sarah mention, we thought that this person would be responding to kids in the moment when they were having a meltdown, and that, teachers could kind of just keep teaching because that person would respond to that chaos, that blowout. So of course, that is not the case. And what we really had to look at is, what do we need to do building wide to address this need in our changing student population? And so what we realized is, yes, we desperately needed mental health support, and that really changed the course of where we were going as a school. So we had that. We realized we needed intervention for kids. As Sarah mentioned earlier, just because a student has behavior needs does not mean that they necessarily need mental health counseling. It may mean that they need some intervention in the classroom. So we kind of started to piecemeal what that might look like for us. And through that journey, we realized we need systems. We need to get some systems in place. And so as a team, we started looking at what was working in other places, how would that work for us? And really, we as a school went through this mindset shift for mental health in our schools and integrated systems. What we did as a result of this journey is we began down the road of professional development, building wide, and our journey really began with multi-tiered system of supports. So what we realized is we needed this framework and in our building to start to organize the things that we wanted to get in place. And so we kind of started at that top tier of, okay, now we have this mental health professional, which is a tier 3 intervention, but we need to be looking at the other tiers in our school. And so looking at that professional development, we spent a lot of time in that year training our staff on MTSS. Our school really dealt with some resistance to implementing PBIS. So we spent a lot more time just training our staff on MTSS. We spent a lot of time training staff about trauma and ACEs and interventions that can work. And once we really built that foundation and we built that knowledge, we started looking at, okay, what does MTSS look like in our school? Our staff was very familiar with RTI and a tiered structure for RTI. And so we used that to say, okay, RTI, that's how we're addressing our academics. It's going to look very similar for how we are addressing behavior, in that we have things that we do for all students, we have things that we do for a targeted group, and then we have more individualized plans. So I know we're going to talk about that here in a few minutes. We also realized that we ourselves as a school needed to be able to respond to students that were experiencing a tough moment, if you will, or several tough moments throughout the day. And so we ended up putting together a team of people, a response team, and put them through training to make sure that they have the skills that they needed to respond to the students in the moment. We did a lot of professional development around de-escalation so that we could get in front of it. We really changed from a reactive to a proactive model where we were trying to keep those things from happening, but also train people to know what to do when they do. So another thing that we did is we established a student support team, which you heard Sarah talk about. This was just pivotal for our school because our teachers were so frustrated with what was happening and they needed help, they needed support. And so that student support team offered that. It's a team-based approach. When we first started, what we had were the teachers that were involved in the student that we were talking about. And then we had our counselor, our school counselor at the time, administration, and then the family. And this offered a structure for everybody to come together to work on a plan to help the struggling student to be more successful. We were very focused around behavior in the beginning because that was our most dire, desperate need. But as it has unrolled, it's really turned into, of course, looking at behavior, academics, and social emotional. So when we all come to the table, we can understand how those pieces work together and what types of interventions we need to have in place that address all of those so that we have a more comprehensive plan. And really providing that structure for teachers to be able to sit down with the parent and then with others in the room that have expertise in the area of behavior and social emotional to say, here's an intervention that I think would work in the classroom, and everybody get on the same page for what that's going to look like, how will we know that it works, what data are we going to collect around that, and then we'll come back together to see how it's working. So that team-based approach really helped our school. And then of course, integrated multi-tiered systems of support, that was the basis for all of the things that we were integrating and helped us to look at the whole picture. So some of the things that we noticed as we went on this journey were that we really needed to have a trauma-informed approach. For our particular student population, that was a huge concern for our kids. And so we needed to provide professional development in that area, but then really start looking at some of the processes that we had in our school. The strength-based thinking versus deficient thinking. Our student support team is very much a strength-based team. And so we look at the strengths of the student and we try to build our plan based off of those strengths rather than looking at what is the student missing. We look at what they have and then we build our interventions based off of that. Redefining discipline, that just became necessary. And so while our journey started not in discipline, it quickly became, okay, now we need to look at this as well. We need to have a trauma-informed approach to discipline. We started looking at our discipline data and we realized that there was some discrepancies in our kids that were in poverty or even our race data. So we started to think about, do we have equitable discipline policies? We continue working on that, especially with the changing policies that have come down from OSPI, that this is a continual process for us to update our discipline policies and procedures and making sure that we are adequately responding with that trauma-informed lens to our students. Another theme that we noticed, and I think is important to point out, is secondary trauma. So as a teacher, when you are dealing with students that have experienced the type of trauma that they have, we need to realize that our teachers are also experiencing some of that trauma, which is considered secondary trauma. And so we recognize that we had a staff that was truly exhausted and needed to have a lot of support. And so I think we realized it's very important that we don't just push that under the rug and hope that it gets better, but we actually did some professional development for our staff so that they could understand the trauma that, yes, they were experiencing. I think having those conversations and bringing awareness to it was very helpful for our staff so that they could say, yes, I am struggling and that's okay. And what can I do to take care of myself so that I can come back and continue doing this job, because it is a very important job and a very difficult job. So for the multi-tiered systems of support, the biggest thing for us in getting it off the ground was spending as much time as possible with professional development. When teachers had an understanding of where we wanted to go and how to get there and what it would mean when we did, they were much more on board because this is very different than how we've approached behavior and discipline in the past. And so making sure that people have an understanding for the why is very important. And then those tier 2 interventions. So as this started to roll out, what we realized is we had a gap. And as I mentioned earlier, you know, we started with a tier 3 intervention, which is not quite the way, you know, you're supposed to do it. However, that was the need at the time. But what we realized is, okay, now we've gotten these foundations in place. We have these universal procedures, but we have nothing between our general ed population and our tier 3. So they were either doing fine in the classroom or they were getting referred to special ed or getting referred to mental health. So we realized, wow, we really need to have strong tier 2 interventions because, again, as Sarah mentioned earlier, and I've already said, behavior difficulties does not mean mental health. And there are so many things that you can do in the gen ed classroom setting to address behavior concerns. And same with special ed, we started to see a lot of special ed referrals specific to social emotional. And what we realized is we need more social emotional universally, and we also need to have tier 2 social emotional. So it's not just either they get it in the classroom or all of a sudden we have to send them to special ed. So those were some of the things that we noticed. So this is really where we started to, as we were implementing our multi-tiered systems of support. So the first thing that we did is we looked at our universal supports. And so as a staff, I know I've mentioned several times how important that professional development was. We spent a lot of that time doing more of a workshop model. And so I think coming together as a staff and building the foundation for the changes in our school really helped with the buy-in and helped to keep it going because people understood the why and they were also part of developing the changes that we were making. And so as a staff, we worked to put together a matrix which had our common expectation. And then we came up with a plan for how we were going to be teaching those expectations. That was brand new for our school. We had never intentionally taught behavior expectations outside of our own little classroom space. And so coming up with that plan together as a staff was really beneficial. We, as a staff, decided what our positive feedback system was going to be. And we started very small. You can see in that little picture there, it says confetti. We decided our positive feedback on year 1 was simply going to be these little tickets, and we were going to hand them out. And if students got, when they were, our quote was acting right, they would earn a little confetti ticket with their name on it and why they earned it. And they put it in the bucket, and a couple times a week we would pull those out on the intercom. It was so simple just to get us started and just to get people in the habit of that positive feedback. And so it was a great place to start because it was so simple. It, of course, has grown since then, but just getting it off the ground. And then we started doing a once-a-month assembly where we would recognize students for meeting behavior expectations. And so again, just that shift for looking more for the positive. We also implemented PACS. So we started with our kindergarten through 2nd grade using PACS in the classroom and saw great growth with that. We're continuing to move that through the other grade levels. Our next step is we're working toward a social emotional learning curriculum. For our targeted group, we started with check-in and check-out. We trained our entire staff on what that program is, how it works, and why you do it. The cool thing that happened with that is when we first trained our staff on it, we had 3 staff members that were willing to run the entire program. And we had kids that were nominated, and these 3 staff members were going to take it on. However, when we trained our staff on what it was and how it worked and the benefits to it, we went from 3 people to 30 people saying, hey, I want to be a part of this. I'm willing to lead a check-in and check-out for a student. I'm willing to be their person. And so, again, I think giving the why to them really empowered them to be part of that and made a huge difference in getting some of these things off the ground. We started doing social skills groups. Obviously, kids that were in special ed were accessing that, but we wanted to have kids that were just in our general population that needed a little bit more work on social skills to be able to access that. So we started social skills groups. We also started changing the way we looked at recess, and rather than punishment when they were not doing the right thing on the playground, we started a recess reteach where they would come out and they would learn the proper way to play foursquare or line up or go down the slide. So we changed the way that we looked at recess. For our tier 3, getting it off the ground, our HUG program, which stands for Hello, Update, and Goodbye, is more intentional than check in and check out in that the goals were more specific to the student. The goals were developed through our SST process, and they have more frequent feedback during the day. Some students were able to go and work with our counselor on zones of regulation. And then we also started developing behavior intervention plans. And those behavior intervention plans were developed during our SST process. And so again, that's when we had all of the teachers there and the family and some expertise in behavior and academics. So we were able to come up with a comprehensive behavior plan that everybody was trained in, on board for, understood how to implement it. And we saw a lot of success by coming together as a team to develop those plans. So a process for building the system, the work spread in our district. We first started by having a district MTSS leadership team. And from that work, we started going back to our schools, training our schools, and then getting together a school-based team. So by the end of that first year on our district leadership team, everybody had started a school-based team so that we could begin bringing some of that work back. As those teams grew and developed, it started to build capacity within our own school. And so now all of our schools have a tier 1 team, and they also have a tier 2-3 team. We used so all of our schools do TFIs, the tiered fidelity inventory, to look at the systems that we do have in our school. And then we develop action plans. And so all of our schools in our district currently use the TFI twice a year and develop our action plans based on that information. And then we make sure that those action plans and the goals are connected to our school improvement plans. And so that keeps it part of the conversation. And then again, I know I've talked a lot about professional development, but that was just huge for us. So ongoing professional development, because as you know, each year is different. The needs in your school are different, the students are different. And so making sure that the staff has the skills that they need to be successful has been huge. So ongoing professional development. So advice that we would give people, mindset shift. It really does take a mindset shift to begin addressing these things in your school. Using that professional development and meeting with your staff to build buy-in, both with your staff and your families and school community, is huge for this to be successful. Focusing a lot on relationship building and making sure that people understand how to build relationships. We're asking teachers to build relationships with students that might be our most difficult and might struggle to build relationships. And so being really intentional to teach our staff how to build those relationships with kids that may have experienced trauma is really important. Our student support team, so making sure that you have some sort of a team in place to access student supports and intervention, and just having a team that people can be part of to build those plans, to understand how to collect data, and then ensure that things have been implemented with fidelity. So establishing that student support team as soon as you can, very important. And then that last note there, continuous cycle of improvement. And so understand that this is part of a process. We're a couple years in and we continue to try and improve every year. We're never done because things are continuously changing. But having that action plan that we talked about earlier and coming back to it at least every year was important to carry that work forward. And then continue what you've started. And so if you haven't gone back to revisit the places where you started, making sure that you have a plan for doing so, because as you get new teachers and new staff, you want to make sure that everybody has been trained on the foundation where you started. So these would be, I guess, the words of advice as you begin this process.
Thank you, thank you, thank you. That was awesome. We'd like to get some more information from you about our webinars, so we're going to run our evaluation as a poll today. Your feedback is important to us and will help us bring you topics you would like to hear. We have some resources. We're kind of running out of time here, so I'm going to be really quick. We recommend you read Integrated Multi-Tiered Systems of Support, Blending RTI and PBIS by Kent McIntosh and Steve Goodman. There's Mental Health First Aid Training, SHAPE Playbooks, Advancing Education Effectiveness, teaching social and emotional competencies within a PBIS framework. We have one other thing that we've been asked to share with you, and that is that the Office of Superintendent of Public Instruction and the Healthcare Authority have developed a quick survey in hopes to better understand the existing relationships, services, and needs between schools and behavioral health, meaning mental health and substance use disorder treatment providers, in addition to gaining an understanding of school-based services being offered. I believe Ronnie will put the link in your chat. If you'll take their survey for them, they'll really appreciate it. And next month, our topic is graduation. The Graduation 101 will be supporting what's next. Graduation 201, alternative learning experiences. We like to give credit where credit is due. If you liked an image from the Gate Equity webinar, we use images that are in the Creative Commons or are tagged with their individual permissions. Most of the graphics used today came from the Noun project. I want to thank Ronnie Larson for giving you all the links, Kepi for making sure this moves smoothly, Megan, Sarah, and Chelsea for all their awesome information. As we wrap up today, we want to encourage you to take a moment to reflect on the webinar and discuss these questions. You can use the chat, the people around you, or just jot down some thoughts on a sticky note. We'll be here to answer questions for a little while, so take advantage of the opportunity to talk to our presenters with the Q&A. Thank you and have a great day.